The topic about which we are going to discuss about today is space maintenance. Let's see about the importance of deciduous dentition. It acts as a natural space maintainer. It's for speech, aesthetic, psychological well-being, mastication, growth stimulation. Let's see about the definition. Let's say about the preventive orthodontics. It is defined as the action taken to preserve the integrity of what appears to be normal occlusion at a specific time, and this was given by Graeber. And let's say about interceptive orthodontics. According to American Association of Orthodontists, it is defined as that phase of orthodontics employed to recognize and eliminate the potential irregularities and malposition in the developing dentofacial complex. Let's see about the objectives of space maintenance. Preservation of primate physiological and leeway space, and second objective is preservation of the integrity of the dental arches, and third is preservation of normal occlusal planes. It should aid in aesthetics and phonetics. And now let's see about the changes seen after premature loss of teeth. Dentition is designed to function as a single unit retained spatially by the sum of forces exerted upon each individual member. Three distinct forces, occlusal, muscular and eruptive forces, contributed to spatial closure. Now let's see about the space maintenance. It is defined as the process of maintaining a space in a given arch previously occupied by a tooth or a group of tooth. Provision of an appliance with control of space loss. Now let's see about the space maintainer. It's a fixed or removable appliance designed to preserve the space created by the premature loss of a primary or a group of tooth. Now let's see about the space management. It includes measures that diagnose and prevent or intercept so as to guide the development of dentition and occlusion. And let's see about the space control. Gainsforth in the year of 1955 defined it as careful supervision of the developing dentition. It reflects an understanding of the dynamic nature of occlusal development. And here we can see that the proximal caries is on 8.5, and as a result it caused the loss of tooth materials. So as a result of loss of tooth material, so there is supraerosion of the opposing tooth, as well as there is supraerosion of 5.5, and the adjacent tooths there would be migration. And in that case, we should go for extraction of the caries tooth in ratio of 8.5, and no space for permanent tooth would be there. So if we are going for the proximal restoration, then their permanent teeth is in the proper position during the transition of this dentition. And now let's see about the first primary molar area in the mandibular, and high tongue position plus strong mentalis and buccinator damages the occlusion after the loss of mandibular primary molars. A collapse of the lower dental arch and distal drifting of anterior segment will be the result. The potential for space loss is greater during eruption of the first permanent molar, since this is the time when permanent molar exerts a strong eruptive force against the distal crown surface of the second deciduous molar. Now let's see about the maxillary aspect. Usually first permanent molar erupts distally and begins a rotation to swing forward once the cusp tip appears through the tissue at the eruption site. The permanent molar then contacts the second deciduous molar. However, at the time of contact, there should be a space maintainer in place to resist the potential for mesial displacement of the second deciduous molar. In this picture, D is lost before the eruption of the 6, and there is mesial migration of E and mesial bodily movement of the 6. And so there is inadequate space cause impaction of the premolar. And here the D loss during eruption of the anterior tooth. Then the anterior tooth use the space created by the loss of D for their alignment. As a result, E is replaced by 5 and the first premolar is impacted in this case. So now let's go for the second primary molar area. In the maxillary aspect, second deciduous molar normally serves as a buttress for the permanent molar eruption. If the latter is missing and no space maintainer is placed, it is common for the maxillary first permanent molar crown to continue to swing mesially, thus blocking out the second premolar. Now let's see about the mandibular aspect. The mandibular first permanent molar strongly depends on the presence of second deciduous molar distal crown surface for eruptive guidance. Thus, if the deciduous tooth is lost during permanent molar eruption, the latter will continue its mesial eruption pathway to produce a severe space loss. Here, E is lost before eruption of 6, and so the 6 moves mesially within the alveolus. And as a result, the 6 contacts D, leading to impaction of premolars. And here E lost after the eruption of 6, then there would be a mesial tipping of the 6 and inadequate space causing the impaction of the 5. And now let's see about the primary canine area. There is early loss of deciduous canine, upper or lower, is more common due to the erupting lateral incisors rather than because of the caries. Early loss of primary canine would contribute to an additional decrease in circumference of arch by permitting lingual tipping of permanent incisors from force of occlusive orbicularis oris and its associated muscles, which reinforce with a space maintainer. So now let's see about the primary incisor area. If tooth loss occurs at age close to the normal exfoliation, space maintainer is not needed at all. And aesthetic, speech, function, psychological effects. Ideal requirements of space maintainer. It should maintain the mesiodistal dimension of the tooth, should not interfere with the eruption of the adjacent teeth or permanent teeth, should be functional so as to prevent the supra-eruption of the opposing tooth, should be as simple and strong as possible, should be easily adjustable, must not harm the remaining teeth by imposing excessive stresses on them, and should not interfere with mastication, speech and egglutation, must be easily cleansed and not serve as trap for food debris and irritate soft tissues, and it should be durable and corrosion resistant. Now let's see about the contraindication. When there is no alveolar bone overlying the crown of erupting tooth, mucosal covering, and there is sufficient space for its eruption. And the second contraindication is that when space left is excess of the mesiodistal dimension required for the eruption and space loss is not expected. If the X-ray of extraction region shows 2/3 of the root of succedaneous tooth is already calcified. The fourth is that when there is gross space discrepancies requiring future extractions and orthodontic treatment. Now let's see about the factors governing the selection of the appliance. First one is that patient cooperation. Second one is appliance integrity. Third is maintenance. Fourth is modifiability. And fifth is limitation. And sixth is cost. And seventh is time. Now let's see about the classification according to Hitchcock, who has given in the year of 1973. And let's see about the classification as well as example. In case of removal, the example is acrylic partial denture type, and for fixed is band or crown and bar appliances. Semi-fixed band or crown and loop appliances. With bands or banded band and loop appliances. Without band or non-banded, it's removal type. For functional, band and bar appliances. Non-functional, transpalatal arch. For active, Gerber space regainer. And for passive, band and loop appliances. Now let's go to the second classification, that is according to Raymond C. Thoreau in the year of 1978. He classified it into removal, which complete arch, lingual arch, extraoral anchorage, and then the for individual tooth, band and loop. Now let's see about the planning for space maintainers. First one is that time elapsed since tooth loss. Advised to place as soon as the primary tooth is lost, and maximum space lost within 6 months after loss of the tooth. And the second thing is that dental age of the patient. Last tooth erupted in the oral cavity. Third point is that amount of bone covering the unerupted tooth. The more the bone covering the unerupted tooth, the more the time it would take to erupt. Normally, premolars take 4 to 5 months to erupt through the bone or through a bone of 1 mm. And there is early removal of primary molars may delay the eruption of premolars. And now let's see about the fourth point, that is amount of space loss. For maxillary spaces close faster as compared to the mandibular spaces, and for second deciduous molar will cause greater space loss. Now let's see about the rate of space closure. For the first maxillary molar, it's 0.8 mm. For the second maxillary molar, it's 2.2 mm. For the first mandibular molar, it's 0.9 mm. And for the second mandibular molar, it's 1.7 mm. And maximum space is lost during first 6 months of extraction. Most immediate loss is within 76 hours. And the sixth point is that eruption status of the succedaneous tooth. Estimated by amount of root completion, 2/3 of the root formation for eruption. And seventh point is congenital absence of the permanent tooth. If congenital missing, then retain the space for replacement. Now let's see about the 8th point, that is it's the sequence of eruption. And the 9th point is delayed eruption of the permanent tooth. Ankylosed primary or impacted permanent teeth leads to delayed eruption process. And 10th point is available space. An evaluation of available space should be performed to determine whether the deficiency is developmental or a result of pre-existing condition. And now let's see about the 11th point, that is arch length adequacy, estimated by position of incisors, leeway space and incisal liability. And the 12th thing is the congenital absence of permanent tooth. If congenital missing, retain the space for replacement. Now let's see about the 13th point, that is the miscellaneous factors. This includes growth of jaws, proximal caries, wear and attrition. And 14th is interdigitation. And now let's see about the 15th point, that is the oral musculature and oral habit. There is a strong mentalis muscles. And some of the types of model analysis are Moyer's mixed dentition analysis, Huckaba's analysis, Hickson and Oldfather's analysis, Tanaka-Johnson's analysis. And now let's see about the fixed and it's a fixed and removal space maintainer. Fixed space maintainer. The advantages are bands and crowns are used which requires minimum or no tooth preparation at all and do not interfere with passive eruption of abutment tooth. The jaw growth is not at all hampered here, and succedaneous permanent tooth is free to erupt and can be used in uncooperative patients, and masticative function is restored if Ponticks is placed. Now let's see about the disadvantages. Elaborate instrumentation with expert skills are needed and may result in decalcification of the tooth material under the band. Supra-eruption of the opposing tooth can take place if Ponticks are not used. If Ponticks are used, it can interfere with vertical eruption of abutment tooth and may prevent eruption of the permanent tooth if the patient fails to report back. Now let's see about the space maintenance for premature loss of deciduous first molar, unilateral loss for maxilla and mandible, band and loop, crown and loop, band and bar, and removal function. And for the bilateral loss, in case of maxilla, we go for Nance palatal holding arch, bilaterally placed loop, band and loop, removal function. And for the mandible, it's lingual arch after the eruption of permanent incisors and bilaterally placed band and loop before the eruption of permanent incisors and removal functional. Now let's see about the space maintenance for premature loss of deciduous second molar. Unilateral loss, band and loop space maintainer when permanent first molar has erupted. Reverse band and loop, permanent first molar has not erupted. There is a large pericoronal flap, removal functional. Bilateral loss for the maxilla, it's Nance palatal holding arch if permanent first molar are erupted. Reverse band and loop, permanent first molar has not erupted. Bilateral band and loop are indicated if permanent first molars are erupted. And removal functional. And in case of mandible, before eruption of the first permanent molar, we should go for two distal shoe, one on each side, or reverse band and loop. After eruption of the first permanent molar, we should go for lingual arch if permanent incisors are erupted, and bilateral band and loop if permanent incisors are not erupted, and removal functional. And let's see about the space maintenance for the premature loss of deciduous canines. In case of unilateral loss for the maxilla and mandible, it's band and loop, and deciduous first molar acts as the abutment. For bilateral loss, in case of maxilla, it's Nance palatal arch, and for mandible, it's lingual arch if permanent incisors are erupted, and bilateral band and loop. Now let's see about the armamentariums. Stainless steel band materials or preformed bands are needed. Pliers, contouring pliers, band forming pliers, band seater or pusher, band adapter, hoe pliers, straight and curved, band cutting scissors, bird beak pliers, crimping pliers, three-pronged pliers, universal pliers, stainless steel wires, round 21 or 22 gauge, spot welding units, soldering units, silver solder, flux, wire cutter, finishing bars and polishing stones. These are the armamentariums which we normally use. And now let's see, according to the band materials, for anterior tooth, the band materials used are 0.003 into 0.125 into 2 inches. For the bicuspids is 0.004 into 0.150 into 2 inches. For the primary molars, we go for 0.005 into 0.180 into 2 inches. For the permanent molars, the band material is size of the band material we go for is 0.006 into 0.180 into 2 inches. And let's see about the differences in pinching upper and the lower bands. In the upper molar band, pulled from palatal side, and the lower band pulled from the lingual side. And the seam of upper and lower band kept at mesiolingual line angle seem to be placed opposite a cusp than a groove. Occlusal surface of band just below the crest of the marginal ridge, gingival 1 mm into gingival sulcus. Band is generally removed and closer seam is spot welded. Okay, here place separators interdistally for the ease of band adaptation and select the band material. The band is checked for the two contrasting side, that is the dull and shiny side. The dull side goes next to the tooth, and shiny side should come faces the outward side. The dullness helps to hold the cement in place, while the shiny side lets the food slide off. So about 2 inches of the band material is cut off with straight scissor, and a loop is made with two dull sides against each other. This has to be spot welded to hold its position, and the tangent end of the band materials are rounded with curved scissors so as not to cut into patient's cheek. The band material is then slipped down the tooth stretcher, and then pinching is made with band forming pliers. It is better to have the seam opposite a cusp than a groove, as it requires more thickness into the, and mark the excess that is present on the buccal lingual aspect with help of glass marking pencil. Trim the excess off and retry mesially and distally. The occlusal surface of the band should be just below the crest of the mesial and distal marginal ridges and just above the contact areas. The band carried by hoe pliers is placed down the tooth by using the thumb as if will comfortably go, keeping the tails of the band is the hoe pliers. Holding the band in place, we have to squeeze the hoe pliers up against the crease formed by the two tails of band materials. Now the new closer seam is spot welded with 3 or 4 spot welds at this point. Festooning is done with a curved scissors. Crescent shaped piece of band material are removed from the cervical mesially and distally, and these concave cuts are blended into the buccal and lingual cervical portion of the band by trimming bars. Band is now ready for final seating. After placing the band, pull the band from the lingual aspect, squeezing the excess out, hold the band firmly in this position. With the help of finger pressure from buccal aspect, and pinch the band with big pliers. And remove the band and spot weld at the new contact, cutting the excess off. Now refit the band and fold the seam. And remove it and solder the seam, trim any sharp points and polish the band before refitting. Let's see about the festooning. Countering of band in order to follow gingival margin proximally, and trimming is that it involves reducing on buccally and lingual side to avoid occlusal interference and adjust occlusal cervical length of the band. Now this is the band and loop space maintainer. Indications are for the maxilla and mandibular arches, premature loss of first primary molars, premature loss of second primary molars after the first permanent molars erupted, or even after the distal shoe has been removed, and bilateral loss of single primary molars before eruption of the permanent incisors in case of premature loss of the primary canines. And the advantages are that construction is easier and faster and requires less chair time, allows transverse growth of the jaws. Many modifications are possible. The disadvantages are non-functional, does not restore mastication, does not prevent supereruption of the opposing permanent tooth, may lead to slight mesial tipping if the loop slips between the contact area, cannot stabilize the arch, cannot be used for multiple loss of tooth, and cantilever, carries high children, cannot be used. Steps in band and loop space maintenance construction are: fabrication of the band, take an impression, place the band in the impression and stabilize it, adapt the wire loop, solder the loop to the band, and smooth and polish the appliance, try in and cementation with luting GIC. This is the curve formation with 3-prong pliers. Okay, this is the curve formed with the help of 3-prong plier, and this is a mucosal adaptation and marginal adaptation of the loop and complete loop placement. A design of the wire loop: the arm of the loop should be placed in the junction of the middle and cervical third at the time, not interfering with occlusion. And the contour of the loop should be similar and as close as possible to the gingival contour. The final width of the loop should be wide enough to allow eruption of the premolar inside the loop. And the loop should be placed just above the contact area of the supporting tooth in a passive manner so as not to slip down. Distal end of the loop to overlap of buccal and lingual surface of bands. And this is the pre-operative, and this is post-operative with band and loop on 8.5 and stainless steel crown on 7.4. This is an example of full mouth rehabilitation. Pre-operative upper arch, pre-operative lower arch, pre-operative front view. The pre-operative upper arch band loop on 5.5 and 6.5, and the post-operative crown or loop on 8.5 and fiber splint on 7.4 space. Let's see, it's the modification crown and loop. Indications are, most of the indications of the band loop appliance also applies to the crown loop. The crown is used in preference to the band when the abutment tooth is highly carious and exhibit marked hypoplasia, pulp therapy tooth, and this is a reverse band and loop and band and bar. Advantage is that no harm to the gingiva, functional, and no super eruption is there, and loop only on one side. This is bonded loop, long band and loop. Its mains appliance. This is the crown, band and loop. Lingual arch space maintenance. The indications are to preserve the space created by multiple loss of primary molars in lower arch. This appliance prevents lingual collapse of lower anterior tooth and bilateral and unilateral loss of primary molars after eruption of the lower permanent incisors. And designs of the wire loop. The arch wire should contact the erupted permanent incisors at the cingulum. Arch wire should be located 2 mm below the gingival margin or edentulous ridge in the posterior regions to prevent the distortion under process of mastication, and should be located 1 to 2 mm lingual to the posterior tooth to permit satisfactory eruption of the bicuspids in a buccolingual plane. The arch wire should meet the band at the mesiolingual cusp slope, and at the same time place the soldered joint in the middle third of the band to avoid the occlusal interference. The advantages are many modifications are possible and can also be used to regain the spaces and arch holding space maintenance, and disadvantage is that construction is difficult and chances of distortion of the appliance by tongue pressure may cause unwanted movements cannot be given until lower permanent incisors have erupted fully. And the modification is that horse lingual arch with U-loop used for space regaining, removal lingual arch, and omega bends in canine region to prevent interference, and lingual holding arch with spurs. Now let's see about the Nance palatal arch. Here is mainly used for the maxillary arch. We use this for the maxillary arch, and it's bilateral, fixed, non-functional, and passive. Indication is that when there is bilateral missing primary molars in the upper arch, also for maintaining the maxillary first permanent molar positioning with no loss of space in arch and a favorable mixed dentition analysis. This is the Nance palatal arch. And designs of the wire loop are that the arch wire extends anteriorly without touching the against the surface of the primary molars. At the arch area, the small U-shaped band at the rogue area, a small U-shaped bend should be incorporated in the wire, which is approximately 1 to 2 mm away from the soft tissue. The bend will enhance the retention of the acrylic to the wire. The acrylic button 0.5 inch in diameter is placed usually on the descending portion of the palatal vault 1 to 2 mm below the incisal papilla. The advantages are that economical as compared to band and loop, maintainer being placed if there is bilateral loss of primary molars and allows growth transversely in the intercanine areas. And the disadvantages are requires more clinical skills and dexterity, irritation to the palatal tissues, palatal button plaque formation cannot be used in patient allergic to acrylic, and growth retardation in molar areas. And the modification is that by incorporating tooth, it can be used to replace missing anterior tooth, fixed functional space maintainer. It can be made active by incorporating U-loop to the wire, and opening the loop cause distalization of the permanent first molars, and it can be used as a remainder appliance for habits by incorporating spikes in the acrylic button. And this is a maxillary arch preoperative, maxillary arch and fixed functional modified Nance palatal arch with soldered crowns, and maxillary arch postoperative with modified Nance palatal arch, mandibular arch postoperative with band and long loop on 3.6 and crown and loop on 8.5. Now let's see about the transpalatal arch. It's mainly used for unilateral, fixed, non-functional, and passive, and mainly maxillary. And the appliance is designed to prevent the first permanent molars from rotating when primary molars are lost. And the indications are, the best indication of transpalatal arch is when one side of the arch is intact and several primary molars on the other side are missing. The contraindications are in maintenance of bilateral spaces, example loss of both second primary molars, design of the wire loop. The transpalatal arch runs directly across the palatal vault, avoiding contacts with the soft tissue. U-shaped bend must be given to the wire in middle of palate. As it approaches to the mesial part of the palatal surface of the band, the wire should be bent to the distal part of the band to assure a better joint. The modifications are, first modification is that arch expansion appliances. Second is that space regainer to distalize permanent molars. Now let's see about the distal shoe appliances. It's also called as intra-alveolar appliances, erupting guiding appliances, intra-gingival appliances. And indications are indicated when there is a premature loss of second deciduous molar before the eruption of the first permanent molar. And Roche's distal shoe or modification of it using crown and band appliances with a distal intragingival extension V-shaped end, which offers a broader surface and helps prevent rotations. The broader surface also holds a greater surface of a chance of success if the unerupted tooth is positioned buccally or lingually in the dental arch. Distal surface of the second primary molars provides a guide for unerupted first permanent molars. When the second primary molar is removed prior to the eruption of first permanent molar, the intra-alveolar appliances provides greater control of the path of eruption. And the disadvantages are that small metallic tattoo may form at the space when the vertical components enters the gingival. Controversy exists regarding the healing at the site of invagination of the vertical components. And now let's see about the contraindications. If severe teeth are several teeth are missing in the same quadrant, as there is a lack of adequate abutment, medical compromised patients such as bloody psoriasis and congenital heart defects, previous history of rheumatic fever, diabetes mellitus, generalized debilitation and immunosuppression, and in cases of poor oral hygiene, lack of patients or parental cooperation, and congenitally missing first permanent molars. Now let's see about the steps in construction of the distal shoe appliances. The first visit, take an X-ray and prepare the abutment tooth with band or if giving crown, and place the prepared band of preformed stainless steel crown on the prepared tooth, and take an impression and transfer the band or crown to the impression. The mesiodistal length of the horizontal position of the distal shoe should be as long as the maximum width of the second primary molar, and portion of the plaster model is trimmed off to obtain the necessary space on the model, and material to be used stainless steel wire, and fabrication of the distal shoe is complete and is ready to be soldered as the to the stainless steel crown with silver solder, and complete crown distal shoe space maintainer. Next visit, extract primary second molar and control bleeding. Distal shoe appliance is tried in the mouth, and an X-ray is taken to confirm the location of the distal shoe in relation to the erupting first permanent molars and cementation. Design of the wire lobe. Using first primary molars abutment, the stainless steel band is adapted and an alginate impression is made. The band is removed and placed in the impression, and a stone model is prepared. The tissue bearing loop is then constructed, contoured with a 20 gauge wire extending distally into the prepared opening on the model, and the free ends of the loop are soldered to the band. And understanding of the normal paths of the eruption of the maxillary and mandibular first permanent molars. In the lower arch, distal extension of the appliance should have a slight lingual position of the crest of the alveolar ridge in order to engage the mesial contact area of the first permanent molars, and distal extension of the maxillary appliance should be slightly facial to the crest of the alveolar ridge. The width should be closely approximate to the normal contact area of the distal surface of the second primary molar being replaced, and length of the distal extension horizontal bar correspond to mesiodistal width of the second primary molars. Depth of the gingival extension, that is the vertical bar, is also an important factor, and not too long or too short. The first permanent molar could erupt underneath the appliances. A good preoperative radiograph should be thickness of the overlying soft tissue. This will aid in determining the depth of the groove to be cut in working model for constructing the gingival extensions. And gingival extension should extend about 1 mm below the mesial marginal ridge of the first permanent molar, just sufficient to capture its mesial surface. Before the final placement of the space maintainer in the mouth, a radiograph is taken to determine whether the tissue extension of the appliance is in proper relationship with the unerupted first permanent molar or not. Final adjustment in length and contour of the distal shoe can be made at this time, and it is best to cement this appliance immediately after the extraction. And the advantages are that only space maintainer, which can be used if there is premature loss of the primary second molar before the eruption of the permanent molars. And the disadvantage is that it can cause the deviation of permanent molar, tooth bud, and may permit tipping if not placed properly, and can interfere with epithelialization of the socket and can cause infection. Retention is not good. Construction is very difficult. And the controversy is that first, there have been reports of trauma and damage to the unerupted permanent tooth by the appliance, and normal eruption of the lower first permanent molar rarely contacts the root surface of the second deciduous molar and does not use the root for eruption guidance at all. Instead, the lower first permanent molar erupts occlusally to contact the distal crown surface of the deciduous molar, and uses it as a buttress for uprating and establishing a mesial position. In that case, it is felt that an appliance is necessary only to replace and to stimulate the distal crown surface of the loose deciduous molar. It is not necessary to consider an appliance that inserts into the tissues. A pre-operative lower arch, a post-operative lower picture, and this is IOP of the distal shoe. Now let's see about the reverse band and loop. An alternative to the distal shoe appliance, placing loop in the horizontal arm of the space maintainer. Space maintainer is placed after signs of eruption of the first molar are seen, and vertical extension is short and is not placed intraalveolarly. It just touches the mesial surface of the erupting permanent molars and gingival saddle appliance. These are the other options: nickel chromium crown placed in relation to 5-4, 5-5, 6-4, 6-5, and pre-operative mandibular arch showing decade 7-4, 7-5, and caries in relation to 8-4. Nickel chromium crown placed in relation to 8-4, 8-5, and removal functional appliance. Space maintainer placed in relation to 7-4, 7-5 following their extraction. 20 months follow extraction eruption of 7. Now let's see about the anterior aesthetic function of space maintainers. Fiber reinforced composites, FRC resins, and flowable composite cured using light curing unit along with bonding agents. This is a pre-operative tooth in occlusion, palatal view with fiber splint. Replace 5-1 and 6-1 with fiber splint. Space maintenance in primary anterior region. The space maintainer consists of an artificial tooth, polycarbonate or acrylic, processed onto a palatal placed arch, which in turn is attached to bands for the molars. Stainless steel bands or crowns are fitted to the deciduous second molar. The post wire should be placed so that it will lie in the middle of the replacement tooth when the replacement tooth is set in the arch of the model. The post wire should be looped around the palatal arch, tightened and held in place while it is being soldered. After soldering, the post is best bent incisively to confirm the curvature of the arch. The appliance is removed from the model and polished, and the tooth is contoured to the gingival contour and positioned to the in the arch. Tooth built up required using composite resin Grubau's appliance. This is the pre-operative view, and this is the Grubau's appliance and the post-operative view. Extraction in relation to 5-1, 5-2, 6-1, 6-2, and the nickel chromium crown in relation to 7-4, 7-5, 8-5, polycarbonate crown in relation to 5-3, 5-4, and Grubau's appliance, placement of Grubau's appliance, and post-operative frontal view. And these are the this is a type 2 ECC early childhood caries using Grubau's appliance. And now this is the remote space maintainer, unilateral non-functional functional space maintainer, bilateral non-functional space maintainers. This is a unilateral functional space maintenance and bilateral functional space maintenance. And remote space maintenance classifications are according to Burroughs: class 1 unilateral space maxillary posterior, class 2 unilateral mandibular posterior, class 3 bilateral maxillary posterior, class 4 bilateral mandibular posterior, class 5 bilateral maxillary anterior posterior, class 6 bilateral mandibular anterior posterior, class 7 one or more primary or permanent anteriors, class 8 complete primary. And this is a pre-operative frontal view and pre-operative occlusal view, post-operative view. And indications are: aesthetics is of importance, abutment cannot support a fixed appliance, cleft palate patients, permanent tooth are not fully erupted for adaptation of the bands, multiple loss of deciduous tooth. And the contraindications are: lack of patient's parent cooperations, and patient has not attained mental age of 3 years, patient allergic to acrylic materials, and epileptic patients, children with high caries activity. The advantages are: easy to clean and permit maintenance of proper oral hygiene, restore vertical dimension, helps in mastication, band construction, elaborate skills are not required at all. Alteration can be made without changing appliances. Disadvantages are: may be lost or broken by patients, cannot be used in uncooperative patients, and patients may not wear them. Lateral jaw growth may be hampered, may cause irritation and allergic to underlying tissues. The advantages are: construction is easier and faster, requires less chair time, allows transverse growth of the jaw, and many modifications are possible. The disadvantages are: non-functional and does not restore mastication, and does not prevent supereruption of the opposing permanent tooth, and may lead to slight mesial tipping if the loop slips below the contact area, cannot stabilize the arch, and it cannot be used in the multiple loss of tooth, cantilever and caries high children cannot be used. Thank you.